Okay, so this section is the male reproductive section. Let's do this question. This question is talking about a 9-month-old boy is brought to the emergency room by his parents because of a 48-hour history of a bulge on the left side of his groin. Parents report that when the child cries, the bulge increases in size, and when he is quiet, it disappears. Physical examination shows an easily reducible soft mass in the left scrotum. Which of the following best describes the relationship of the hernial sac? Okay, so this is some sort of hernia, so at least we can think of like hernia in the groin region, right? So we're talking about hernia in the groin region. First, we need to identify what hernia it is, and then we can look at it, what are the choices and how will the choices help us. Just by looking at the answer choices A, B, C, D, it looks like they want to know the anatomy of this hernial sac. Okay, let's do this. So hernia in the groin area are, let me change my pen, are femoral hernia. Okay, so there's femoral hernia, and then there is direct inguinal hernia, direct inguinal hernia, and then we have indirect inguinal hernia. That's the three types of hernia. We should be able to differentiate between them to see which one of these are actually the type of hernia that this question is talking about. Femoral hernia is easier for me, so I will just focus on the F. Femoral hernia is common in females. Okay. And the hernia sac actually goes through the femoral canal. Okay. And other things to differentiate is this hernia occurs because there is weakness in transversalis muscle or fascia. In this case, we can say the fascia. Okay, so the weakness is in that, and this hernia almost always occurs under the inguinal ligament. Under inguinal ligament. Inguinal ligament. We're running out of space. Okay. What else? The hernia always goes in the femoral canal, and the content of the femoral canal is from lateral to the medial is navel, nerve, artery, in vein, and then the femoral canal. Okay. So it's always medial to those contents. It's medial to femoral vein. Femoral vein. Okay, so that's the femoral hernia. Let me, you know what I need to do? I need to remove this. No. Yeah, I think this will do the job. Okay. I need to simply, oh, that's not going to do it. I thought this will do it. So what's the point of doing that? Nothing. I need to move this part. No, that one, that's not good. Maybe this. Let's see if this will do it. I don't know. This should do it. Okay. Oh, that's not gonna do it. How do I move it to that side? Anyways, I'll use just different colors. Let's talk about direct inguinal hernia. I'll use red so you can differentiate them because I'm running out of room. Direct hernia, so we'll focus on D. Okay, D. A direct hernia, so let's say direct hernia starts with D. It occurs in older men. Let's say daddy. That's what I want to do, daddy, because of just say elder men. Okay, older or elder men. and I'm using daddy just for the purpose of D. Okay, and it occurs usually due to damage, damaged or because of wear and tear, damaged transversalis fascia or abdominal wall, right? So we can say abdominal wall, and specifically what part of the abdominal wall? Transversalis fascia. Okay, so damage to that area. So I'm using these for that purpose, just to sort of so we have something to work with. And does now inguinal hernia in general, direct or indirect, both, doesn't really matter. They always go over the inguinal ligament, over inguinal ligament. Okay, so that's femoral under and inguinal hernia always over. So that will help us. Okay, and it's always medial, medial to inferior epigastric artery, gastric artery. Okay, that's the direct hernia. It's medial to inferior epigastric artery. Okay, now it usually doesn't go into scrotum. No scrotum involved usually. Okay, just to differentiate between this and indirect, and usually it doesn't involve the internal ring. So I mean, I should say never, not usually. Not involving internal ring, internal ring of the inguinal canal. Okay, let's do to direct. We'll use blue. I mean, sorry, indirect. Indirect. So I'm going to go I, infant. It occurs in infant or children. Okay, so that's one. It occurs in infant. That's the indirect hernia, and it always involves. Okay, so damaged abdominal wall was for this case. I want to include the eyes first, and then I'll give you the other parts. It occurs in infants. It involves the inguinal canal. It always goes through inguinal canal. Okay, whereas the other two does not go through inguinal canal. So I, and always goes into scrotum. So we said scrotum here. Let's just say into scrotum. I'm just trying to do the eyes because it helps me remember it. And it also always enters the internal ring of the inguinal canal. Inguinal canal have two rings, internal and external. Okay, so these are all eyes. It just helps me. Let me highlight them. It just helps me to remember things easier. Indirect eye, it occurs in infant. It involves the inguinal canal. It goes into the scrotum. It involves the internal ring. Okay, so these, when I do it that way, it just for my sake of memorization, it helps me. What else do we? It always goes over inguinal ligament. Inguinal ligament, because all inguinal ligament, yeah. So that's by definition. If you want to differentiate between femoral and inguinal hernia, femoral always goes under the inguinal ligament, whereas inguinal hernia always goes over the inguinal ligament. So that will be immediately you can differentiate between the two. And then if you want to know the difference between direct and indirect, they're both inguinal hernia. Indirect in infant, direct in daddy or elderly. Okay. Um, Other difference between direct and indirect is the indirect goes lateral to inferior epigastric artery. Inferior epigastric artery. Okay, so these are some of the differences. Also, um, when I draw something, it will help too. The weakness in this case in the indirect hernia is this something called process vaginalis. Process vaginalis. So weakness in this leads to, or it doesn't close after testes descend, and that's where the inguinal hernia goes through. Okay, just based on that, let's see what choices we can get. So let's see, can we at least diagnose this? Number one, let me diagnose this because now we know what to diagnose. It's a 9-month-old boy So therefore it should be infant, right? Infant. So far indirect. Brought to the emergency room by his parents because of 48 hours of bulge in the left side of his groin. Okay, so that's nothing unique. All of them goes into the groin area, or they herniate or displaced. So the hernia is usually what? It's intestine. A part of a segment of intestines herniate through these areas. Okay, so that's one thing we should remember. All three of them, the herniation is of intestine. Parents report that when the child cries, the bulge increases in size. Obviously, in all three cases, this is the scenario. Why? Because as you increase abdominal pressure or intra-abdominal pressure, the intestine can push down that opening, and it will herniate or will travel into an opening into an area. Okay, so that in all three cases, this is true. The bulge will increase with pressure. Okay, increase in size with pressure, and decrease with when there's no pressure. Okay, all right. Physical examination shows easily reducible soft mass in the left scrotum. So it's in the scrotum again, in the scrotum. So we'll say it's most likely uh, indirect hernia. Which of the following best describe the relationship? So there's only two things in this question that will help us. This is not femoral or direct. If it was femoral, we'll be thinking of female. If it was direct, we'll be thinking of elderly men. Whereas indirect, we'll be thinking of infant boys or male infant. Okay, so I'm deciding that this is indirect hernia. Okay, let's look at the choices. So if it's indirect hernia, let's highlight that it's indirect inguinal hernia. Lateral to the inferior epigastric, lateral to inferior epigastric meter. So we're talking about inferior epigastric artery. We know that indirect hernia is lateral to inferior epigastric artery. So that's number one, lateral to inferior epigastric artery. Okay, this is also lateral to inferior epigastric artery. Now let's see which of these is true. Okay, so both are lateral to inferior epigastric artery. Inferior to inguinal ligament is femoral, superior to inguinal ligament is indirect hernia. So the answer should be B. Okay, because femoral is inferior to inguinal ligament or under, whereas inguinal hernia is above or superior to inguinal ligament. Okay, so this is the answer should be the answer should be B. Okay, good. So these will be incorrect. Now I want to do one more thing. Let me just show you a drawing that will be very helpful. Let's erase this. Just so we can understand. I like drawing, so you guys know that by now. I like to draw, and you guys like it too, so therefore I get encouraged to draw more. Okay, let's see how do we do this. Let me change color, something like muscle. Muscle should be looking more brownish. Yeah, something like this. Yeah, that's what muscle should be looking like. Okay. um, okay, so here is the rectus abdominis muscles, let's say. Rectus abdominis muscle. Okay, so this is the rectus abdominis muscle. Brown. And let's do here, this is the femoral, so the rectus abdominis muscle, let's say this is the femoral vein. Okay, and then we say femoral artery. Okay, femoral artery. And then femoral artery gives a branch called inferior epigastric artery. Okay, same with vein, they go together like that. Okay. Okay. So femoral artery, femoral vein, and then we have muscle. So rectus, not rectus, rectus abdominis muscle. And then we have red is femoral artery, I'll put A, and blue is femoral vein. Okay, this small artery right here is inferior epigastric artery and vein. So I'll just put artery, it is in red, and then blue is vein, or you can call it vessels. Okay. Okay. So there is inguinal canal. Okay, inguinal canal. Let's do a dotted line. So there's a ring here, and then there is a ring right here. This is the inguinal canal, and I can highlight it with green. Inguinal canal. So this green is the inguinal canal. Okay, so this is the inguinal canal. Inguinal canal. This ring is the internal ring of the inguinal canal, and this is the external inguinal ring, or ring of the inguinal canal. What are we missing? We are missing one more structure. Let's do that, and then that would do the job. And here should be an inguinal ligament. So this would be the inguinal ligament. Okay, so inguinal ligament. This is the inguinal ligament. Inguinal ligament. Okay. Now I'm going to use something and then I'll delete it. Okay. During embryogenesis, the testes develop in the abdomen close to the kidneys, and then they descend. As they descend, they go through this internal inguinal ring, and it goes through canal, okay, and come out of the external ring, and it goes into the scrotum. Okay, so that's where the testes will go. This is the normal pathway of testicular descent. For whatever reason, in some children, this area of the internal ring does not close; it stays open. And this area is called, and the membrane that surrounds this, the innermost layer on the abdominal wall that covers this area, is called process vaginalis. Process vaginalis. Okay. So in children, if this ring doesn't close or this process vaginalis stays open, then intestine with pressure, with abdominal pressure, the intestine can actually go through this ring, go through the canal, and exit here, and then go into the scrotum. So this will be the scrotum. And this is called indirect inguinal hernia. Okay, indirect inguinal hernia. Okay, it goes through the femoral canal. Now, the hernia starts lateral to the epigastric artery. So the abdominis muscle is the medial component, the middle of your abdomen, and this is the lateral side. So as you can see, initially the hernia initiates where? Lateral to epigastric and to the femoral arteries. Okay, and that's why the answer was the answer that we chose. Direct hernia occurs right here in this area where the external ring is. Direct hernia only goes to the external ring, and sometimes it can go to the scrotum, but it goes over anterior and superior to the inguinal ligament. So I hope this was helpful. What do you need to know? You need to know what is this area called. This area that I'm going to do a triangle right here, yellow. Let's see, yellow. This is called the Hasselbank's triangle. Most of you probably remember. Okay, so Hasselbank's triangle. This area is the Hasselbank's triangle. I'm coloring it yellow. So direct hernia occurs from the Hasselbank's triangle. Indirect hernia occurs lateral to the vessels right here. So this area. Okay. Both of them are above the inguinal ligament, whereas femoral hernia occurs right here in the femoral canal, which is medial to the femoral vein. Okay, let's move on to next questions. Hopefully this was helpful. Okay, so next question is: a 22-year-old man comes to the physician's office because of a painless lesion on his penis. Um, there are genital lesions. Out of the 6 or 8 that I know, only 2 of them are painful. One of them is herpes, um, and most of them are painless. So it's a good way to divide it that way. But let's continue this thing. Sorry. I should read the question, finish it first. A 22-year-old man comes to the physician's office because of painless lesion on his penis. He is homeless and abuses marijuana, cocaine, heroin, and alcohol. Physical examination shows a 2 centimeter irregular shaped ulcer on his penis and erythematous maculopapular rash on his palms and soles. The drug of choice for the treatment of this disease inhibits which of the following bacterial process? Okay. So this question has 2 parts to it. Number one, we have to diagnose what is the disease. Okay, so number one, you have to diagnose what is this condition or infection, whatever he has. Number two, what is the drug of choice for the treatment of this condition? Three, what is the mechanism of action of this drug? Okay, so that's 3-step question. Okay, so number one, let's identify this disease. Let me highlight some of the things that are in the question that would help us. So yeah, whenever it comes to infectious disease, especially like this sounds like STD, I always look for age. Okay, so this is usually going to happen in young people. Okay, so comes to the physician office for painless lesions. Painless lesion. So this lesion that is on his penis is painless. Okay. He's homeless. He abuses marijuana, cocaine, drug, heroin, and alcohol. What did that tell you? All these 3 things, heroin, cocaine, marijuana, and homelessness, tells you that this person is not actually using protection, needles, and stuff like that. So this is most likely STD. So painless ulcer in a young man that is at risk of STDs. Physical examination shows 2 centimeter irregular shaped ulcers. And this ulcer is painless, right? And in addition to the ulcer, there is a rash. A rash that is red, erythematous means red, macules means flat, papule means raised. So this is a mixture of flat lesions. Okay, flat lesions are the one, their color is different than the rest of your skin, so they will be flat like dots. And papules are raised lesions, almost like pimples. So flat and pimple type of lesions that are found on his skin, mixture of those two. And where are these found? On palms and sole. Okay, so for this diagnosis, let's go to diagnosis. What is this diagnosis? We have a painless lesion. Oh, sorry, painless ulcer. Painless ulcer. It's one single ulcer that is irregular in shape. Plus, he has a rash. What kind of rash? Red, erythematous, okay, macular, which means flat dots, and papular, which means papular means raised lesions like pimples. Papular, that's the rash. And where is this rash on? Palms and soles. Okay, out of all the STDs that we know, like chlamydia, gonorrhea, um, or sorry, generally like herpes, like granuloma, venereum, and syphilis. What else is there? Okay, so out of all of those, this is the most likely syphilis. Okay, so I think let me do this. So we already know this patient has painless ulcer, rash, and so forth, but how do we know which one it is? Because there's so many genital lesions. Let me just write down those first and then to see which one it uh, qualifies for. There is herpes. Okay, it's not herpes because herpes is painful lesions. I'm not going to write it down, it takes too much time, so I'll quickly tell you. You guys can write it down and listen. Herpes causes genital lesions that are painful. They are vesicles full of fluid and they can rupture and then they can dry out. And it's obviously caused by herpes simplex virus 2 or human herpes virus 2, herpes simplex virus 2, which is the genital type, not 1. Okay, so that's 1. That's for herpes. So this is not herpes. The next one we can think of is, uh, in terms of viral infection, is HPV infection, which causes warts, right? Genital warts. Genital warts are gray color cauliflower like rough lesions. They're painless. Okay, so they're painless, so that could go for this. They're painless lesion, but they're cauliflower like gray white. Okay, so gray white rough lesions, and they're painless. Okay, but in this person has ulcers. They don't have cauliflower like gray white rough lesions. So that's what warts are, and HPV causes that. So again, that's not our diagnosis as well. These are genital lesions. So the category is genital lesions. Genital lesions. Some of the most common ones. There might be more. These are the medically important ones. Okay. Then we have something called meliscum. I don't know if you guys heard of that. Meliscum, contagiosum. Okay, and this is caused by pox virus. Pox virus, right? Yeah, that's how it. Okay, so these lesions are caused by the pox virus. They're extremely contagious. They are itchy, but they look like red flesh color lesions that are smooth and shiny, and then they're umbilicated. Right in the middle there's a hole, just like a volcano or umbilicated lesion. That's what they will tell you on the question. So this is our condition is a painless ulcer. It's not a raised lesion. Okay, like molluscum contagiosum. Obviously molluscum contagiosum is contagious, so you have to make sure don't share towels, don't share clothing that comes in contact with these lesions. That's how people get it. Okay, so it's not that. What's left? I'm trying to see. Syphilis, right? Syphilis causes painless ulcers, so that is true. So most likely from this we know it's syphilis. But let's see what syphilis causes. Syphilis, let me erase this. Just give me a second, guys. Let me make my eraser big so I can erase easily. Okay, so we think this is syphilis. So syphilis, what is syphilis? Syphilis is caused by a bacteria that is, its name is Treponema pallidum. It's a spirochete. You want me to write it down? Okay, I'll write it down. Treponema, okay, pallidum. I hope I got the spelling correct. It's a spirochete. Okay, so it looks something like this, spiral shape. They're motile, they swim. Usually you can do an exam called for dark microscopy. You will see an organism exactly like this glowing in the dark background. Okay, so syphilis. Now syphilis, what does it do? So syphilis, there's a primary syphilis, secondary syphilis, and tertiary syphilis. The first lesion that the first disease or symptom that syphilis causes is called primary syphilis. It is nothing more than a painless ulcer. Painless ulcer. Okay, and it's called canker. Canker. This person has that. It has a painless ulcer, right? Secondary syphilis occurs weeks to months later. Okay, what is that? What does that involve? It involves fever, mild fever, maybe fatigue, symptoms of like sort of like mild infectious symptoms, systemic signs like fever, fatigue, lethargy, and blah blah blah. But something that is unique, rash, and the rash that we talk about is maculopapular rash. Okay, it can also some patient can also experience arthritis. Okay, so that's the secondary syphilis, but of course rash is the most important one. Then years later, tertiary syphilis occurs. Tertiary syphilis can cause aortitis. Okay, inflammation of the aorta. It leads to thoracic aortic aneurysm. Thoracic aortic aneurysm. Thoracic aortic aneurysm. So that's the aortitis it causes. And the other thing is called something known as neurosyphilis, right? Neurosyphilis. Neurosyphilis is the same thing as tabes, right? Tabes dorsalis. Dorsalis. It is nothing more than um, degeneration of the dorsal column of the spinal cord. Okay, dorsal column of spinal cord. Remember that area of the spinal cord is responsible for position, vibration, fine touch, right? Three things: position, sensing. So it's a sensory loss. You cannot sense your position in space. You cannot differentiate between 2 points, okay, which is called proprioception. So loss of proprioception, loss of fine touch, and loss of sense of position and vibration. Okay, so if I were to draw, I think I'm giving too much. Let's just go here. If I were to draw the spinal cord, okay, remember spinal cord will have something like this, the anterior dorsal horn, okay. Okay, let me close this. White matter and gray matter. So in the spinal cord, this would be the gray matter and the rest would be white matter. And I'll use yellow for white matter so that way we can somehow differentiate. Okay, so that's the cross section of the spinal cord. Now in syphilis, what is the problem? Okay, I'll use green, or let's use red. So the problem is that in syphilis, this area, this is the dorsal column, this, I'm shading it with red. This is degenerated bilateral both sides. So, and this area is responsible for sensing position, vibration, and proprioception. So in syphilis, all those three functions will be lost. Okay, but it looks like this person only has primary, secondary syphilis. Okay, so this person is experiencing a painless ulcer and a rash. Okay, so that's our diagnosis, number one. So we did our diagnosis. Next, the drug of choice for syphilis is penicillin. Okay, penicillin. That's the drug of choice, penicillin. So let's say penicillin. That's the drug of choice. Okay, the mechanism of penicillin is it inhibits peptidoglycan. Okay, so it's a wall inhibitor. And the wall of bacteria is made of what? Peptidoglycan. Okay, it's made of peptidoglycan. Okay, we diagnose this. I'm going to erase all of this because we already diagnosed it. And we know the drug of choice. Then let's go here. Okay. The peptidoglycan is made of something called as N-muramic acid. Okay, sorry. I knew it. I did it wrong. acetyl muramic acid, and then it's attached to N-acetyl glucosamine, and it keeps alternating N-acetyl muramic acid, and the next one is N-acetyl glucosamine. These are sugars, so both of these are sugars. The bond between them is glycosidic bond. Okay, so this bond between these two sugar is glycosidic bond, this attachment. Okay, and similarly this is one layer, and then again the next layer, N-acetyl muramic acid attached to N-acetyl glucosamine, N-acetyl muramic acid attached to N-acetyl glucosamine. Okay, so this is the backbone of the peptidoglycan. It's made of polysaccharides. So N-acetylmuramic acid and N-acetylglucosamine, I call it NAM and NAG, they're both polysaccharides attached by glycosidic bond because they're both polysaccharides, both sugars. Guess what? The next thing is these things are attached by 4 amino acids. 4 amino acids, okay? And these are the peptide components. These are the peptide components. Usually these amino acids, if I remember it correctly, are made of alanine, glycine, something like that, and alanine, glycine, one more. Okay, 4 peptides. So there's 4. That's why I have 4 dots. 4 peptides. Okay, don't forget it's 4 peptides. Okay, so these tetrapeptide bonds, the red one, these are the peptide component. That's why it's called peptido. So the name of this cell membrane layer comes from peptido. It's the peptide. This 4 red dots, alanine, glycine, and so forth. Glycans come from sugar. Okay, so sugar, it's this blue part, just so you know. So this part is the glycan. So that's why it's called peptidoglycan, because this, a single layer of the cell wall is made of tetrapeptide and glycan. They're combined. Okay. Now, how do bacteria make these cell walls? That's important. So an enzyme that makes this tetrapeptide bond, these 4 amino acid, which enzyme attaches those? These are called transpeptidase. Transpeptidase. So that's one. Okay, so that's one enzyme. In another enzyme that combines the NAG and NAM, the glycosidic bond. Okay, those are known as transglycosidase. Okay, so transpeptidase and transglycosidase, or I think it's something similar name, transglucosidase. Okay, the glycosylation. Okay, glycosylase, I think that's what it is. You can check. So penicillin inhibits the transpeptidase. Okay, penicillin inhibits transpeptidase. So that would be penicillin. All penicillin, cephalosporin, inhibits transpeptidase. They're also called penicillin binding protein. Transglycosylase, vancomycin, inhibits that. Vancomycin. Let's go to our choices. Now that we know our choice, we're looking for an answer. In this answer, what are we looking for? We're looking for penicillin. So, we're looking for cell wall inhibitor, right? So cell wall inhibitor is which one? Penicillin. DNA replication. Oh, I don't know why I talked too much. Let me go this then. DNA replication. What drugs would inhibit DNA replication? Those are fluoroquinolones. Quinolones. Okay, an example of that is ciprofloxacin. Glycosylation, inhibition of glycosylation, again, is which one? Vancomycin, right? Vancomycin. Pore formation, I don't know. Maybe you guys can look this up. I don't know, but that's not the answer because penicillin don't do that. Translation is protein synthesis. So there in bacteria have 2 types of ribosomes, 30S and 50S, right? So 30S inhibition is done by who? By tetracycline. Tetracycline. So tetracycline and aminoglycosides. Aminoglycoside. The example aminoglycoside is gentamicin. Example of tetracycline is minocycline. 50S is macrolides or macrolides. Okay, macrolides, which is example of that is azithromycin. Okay, so we know the drug of choice is penicillin, and penicillin inhibits cell wall, so that should be the answer for this question. Okay, so the next question is a 26-year-old man with a gunshot wound is brought to the emergency room. The bullet has penetrated the abdominal viscera. During an exploratory laparotomy, the right testicular artery is ligated. An anastomotic supply from which of the following arteries will maintain adequate arterial supply to the right testes in this patient? Well, it looks like they're simply asking for anatomy in this question. So they just want to know what are the if the testicular artery, so right testicular artery is ligated, so that means the testicular artery supplies the testes. What they're saying is there's an anastomotic supply to the testes as well, so that means there's another artery that supplies the testes. They just simply want to know which of what is that artery. Okay. Will maintain adequate supply to the testes in this patient. Okay, which of the following are anastomosis? So there's anastomosis. All right, let's do this. What I'm going to do is let's draw aorta just for me to make it a little bit easier. So this is aorta. Aorta, and then aorta splits into the common iliac arteries. Okay, common iliac arteries then splits and divides into external and internal iliac arteries. So this will help me a little bit. Okay. Let's go here. So let's say here is the testis. Let's say this is the right testis. I'll put R in it. The right testes. Should we color the testes? Let's color it gray. There you go. Iron. You know what they say? People who are brave, their balls are made of steel, just like Scarface. So I'm gonna give it the steel color. All right. So that's the right testes, and let's go. So at least we know one artery that supplies the testes come from testicular artery. They're branches of the aorta directly. Okay. Direct branches of aorta. These are testicular artery. Now you might say that testicular arteries are very close to where's my other thing? There you go. Testicular artery is very close to renal artery. So let's say these are the two renal arteries. Okay, so here will be one kidney and there's another kidney. If you know that from embryology, metanephros, pronephros, and so forth in the testicular tissue come from the same area. So originally the testes are in the abdomen close to the kidney, and then during the first year the testes will descend to the scrotum with the help of testosterone, first phase, and then to the inguinal canal, and from inguinal canal to scrotum with the help of dihydrotestosterone. And they will drag the artery from here. So originally the testis was right here, okay, and then it descends coming to the scrotal area. So it's going to drag the artery with it as it goes. Okay. Okay. So at least we know one artery of the testes, and that is testicular artery. Testicular artery, and that's from both sides. Each testis will receive testicular artery directly from aorta. Testicular artery. So what do we know about this? Testicular artery is a direct branch of aorta, and it goes through the inguinal canal within the spermatic cord supplying the testes. Okay. They're saying is that this testicular artery is ligated, so it's tied up. Now the testes, this right testis, is not going to receive blood from here. So that means there's anastomosis. So where is it receiving blood from? Well, there's another branch that is of the internal iliac, okay, sorry, the anterior iliac, so internal iliac, so aorta, this is aorta, and this is common iliac artery, and this is external iliac artery, and this one will be internal iliac artery. So a branch of internal iliac artery also comes through the vas deferens, and then it's this artery is called the vas deferens artery, and it anastomoses with the testicular artery, and it supplies uh, the testes. Okay, so let's label this artery. This is artery of vas deferens. Okay. So the second artery we're looking for is the vas deferens artery. Let's look at our choices to see if we have that, and that should help us out. Wow, it's choice A. Okay, that's it. Done. Inferior vesicular artery supplies the bladder, the bottom part of the bladder, bottom half of the bladder. It's a branch of the internal iliac artery. Obturator artery supplies muscles in the groin area, like the um, adductor muscles in the skin of that area. Posterior scrotal artery supplies the posterior half of the scrotum, and premasteric muscle supplies the muscles of the inner thigh, so especially like when you tap the reflex of that area. Okay, so we got our choice. Let's go to next question. Okay, so the next question is: a 50-year-old man with a 10-year history of hypertension, diabetes, comes to the physicians because of a 4-week history of swelling of his left testicle. Excuse me. So there's a swelling of his left testicle. Remember, this section is about male reproductive system, so andrology. So all the questions going to be related to that. His serum creatine concentration was 3.2, so some kidney issues. He is 5'10", weighs this much. He's obese. Okay, his blood pressure is high. Physical examination shows marked edema around the eyes of the lower extremities of the eyes and of the lower extremities to the level of the knees. The left scrotum is enlarged. Left scrotum is enlarged, and the size increases further when patient bears down. Palpation shows a fluctuating. So most like fluctuating means like full of fluid or something. So fluctuating lumpy mass just superior to the normal sized left testes. So it's telling the testis itself is normal. There's a mass that's fluctuating and lumpy above the testis. Which of the following is the most likely cause of these scrotal findings? Okay, so let's see which of the following could be this mass. Okay, epididymal cyst will be above the testes, which is true, but it's a cyst. The cyst is fluctuating, and it can transilluminate, but it wouldn't um, it wouldn't be associated with hypertension and creatine levels. So this question is talking about some creatine issues. Let's do this. So that means there's some problem with the kidneys as well. Okay, what am I going to do? Highlight, right? Yeah, highlight. Because this person's kidney creatine level was elevated, so that we have to consider that as well into this question. There's some edema of the eyes, and there's edema of the lower extremities. Okay, so lower extremity edema. Yeah, lower extremity edema, so up to the level of the knee. So this person has some swelling, and on top of that, his kidney problem. So those things we should consider, and then maybe we can help. So epididymal cyst will be simple. Hematocele is usually requires trauma. Okay, there will be trauma, and there will be blood in the scrotum. Okay, blood in the scrotum, and it will be painful, and there'll be bruising in that area. This question doesn't talk about any of that, so I'm not going to choose that. Hydrocele is simply fluid and usually occurs in children, not in elderly. Hematocele can occur at any age, and hydrocele is fluid filled scrotal mass. Usually doesn't fluctuate. It's not like a lumpy fluctuation. It's a smooth fluctuation, right? Like, okay, and this is because the process vaginalis doesn't close properly, so fluid will accumulate within that area around the testes. So usually it'll be in children and young. and this person's old, so I'm not going to choose that as well. Testicular cancer will be hard, firm mass, either in teenage or young adult in their 20s. Okay, seminoma is in the 20s, and choriocarcinoma, teratoma is in the teenage age. So, again, this mass would not be fluctuating. It's firm, painless mass. That's testicular cancer. And they will give you something else. It wouldn't be increased in creatinine, it would be increased like in the markers like HCG, alpha fetoprotein, and so forth. So, that's not it. Testicular torsion is twisting of the spermatic cord within which we have this testicular artery, and it's at the end of the day there's twisting, there's trauma. In the clinical scenario there will be some sort of history of trauma, and there will be sudden onset severe pain. Okay, and that is because of testicular ischemia or infarction. It's emergency, so this patient doesn't have any of that, right? um, varicocele. Varicocele is a blockage of testicular vein. Testicular vein, it's blockage of that, and accumulation, pooling of blood can lead to edema. So if the testicular vein is is obstructed and it's blocked, what else could it lead to? Um, it can lead to um, a mass just above the kidney that's fluctuating, fluid-filled mass, and it's fluctuating, and it'll be this case scenario looks like that. Plus, if there is the kidney cannot be, if the issue is okay, so so that's one thing. Depending what's the cause, one of the common causes of testicular, I mean the varicocele, is renal vein obstruction. So I think this is will make sense because this person has the creatinine. So renal obstruction, so the kidney cannot be drain its blood, and that can lead to some sort of kidney damage, and so creatinine will be elevated. Okay, which this patient has. Okay, so let's look for that. Testicular abscess will be painful, painful, fever, tenderness. So none of that is there. So testicular torsion, which is sudden pain, trauma. This person doesn't have pain, so that's not it. And cyst, epidermal cyst is painless, so that's not it. The only thing um, that can make sense is the varicoceles. Okay, so let's choose our answer will be varicocele for now, and let's see what is varicocele. To explain that, we need to do something. I need the space, so I'm going to erase all of this. Okay. There is something called superior mesenteric artery syndrome. Okay, superior mesenteric artery syndrome, um, red color, yeah. So there's the aorta. Okay, so there's the aorta, and there is the inferior vena cava, let's say. Okay, all right. Um, so aorta gives you a branch. Let me do something else first. So here will be the renal vein. The renal vein goes this way. Okay, and then next to that, let me change color. How would the intestine look like? Let's make it a little bit like that, yeah. And then here will be the second part of the duodenum. Okay. um, superior mesenteric artery comes from on top of these two, like that. You can see that it can squeeze the superior mesenteric artery, and the aorta can squeeze the renal vein and the duodenum. So let me label it for you. So this is the duodenum. Okay, duodenum, and then this will be the left renal vein. The right renal vein drains directly um, um, into uh, the sorry, yeah, sorry. In this case, what was the thing? The testicular vein, right? The testicular vein will drain into the left testicular vein, drains into this left renal vein. That's what I was trying to say. Okay, let me change color. So there will be the left testicular vein. Let's say the testicular vein. So it comes from the testes. This is left testicular vein. The right testicular vein comes from testes and drains directly into vena cava. Okay, whereas the left one goes into the left renal vein. Okay, so in this condition called um, superior mesenteric artery syndrome, the superior mesenteric artery can squeeze the left renal vein and cause its compression. So when it causes compression, that means blood flow to this vein will decrease. As a result, blood will start pooling in the left testicular vein, and the testicular vein will dilate. The left testicular vein will dilate. But at the level of the testes, these veins, there is a plexus of veins. It's not just a single vein, it gives you like a network. Okay? A network. So imagine, let me use this. These veins, this vein will dilate, will expand, and then here these veins will expand, and this is where it will build into a big clump of veins, and that's what this person is feeling. This is called varicocele. Okay, varicocele. So the symptoms of this will be, of course, edema. That means blood cannot be drained from certain parts of the body, leads to because the renal vein, it will cause to renal failure, renal issues as well. That's why the creatinine is elevated, and that's why you will have the varicoceles. Plus, if the duodenum is compressed, it will lead to nausea, vomiting, and abdominal pain. Okay, so look for those signs. That should be helpful. Okay, just remember that the left renal vein drains directly into the left. The left testicular vein drains directly to the left renal vein. Okay. All right. Generally, they will tell you in the question that this mass, this supratesticular mass, feels like a bag of worms. Okay, bag of worms. I was looking for that in this question. It was not there. Okay, next question. A 25-year-old man comes to the physician because of a testicular lump. Now, this is not a scrotal lump. Remember, previous question it was scrotal lump. There's a difference. This or supra testicular lump. This is actually testicular lump. The lump is in the testes, so you're going to have to think of cancer or abscess, something like that. On examination, a firm, painless, and rough mass is noticed on palpation of the right testis or testicle. Laboratory result shows elevated plasma lactate dehydrogenase level and decreased level of testosterone, estrogen, alpha-fetoprotein, and human chorionic gonadotropin. Which of the following is the diagnosis? So number one, when you think of testicular mass, testicular cancer. So this is most likely testicular cancer because there's a testicular lump, and this lump or mass should be firm, not soft, not fluctuating, painless. Okay. So what else were they saying? Painless, firm, and rough. Okay. Sure, sometimes it's not always rough, but that's fine. So if it's not fluctuating, it's firm, and it's not painful, it's painless and rough, in a young person like that, I'll think of testicular cancer first. But they're telling which of the following is the most likely diagnosis. And plus, what else was there? There was increase of lactate dehydrogenase. Lactate dehydrogenase. Okay, so let me highlight those to make sure that I got it correct. Sometimes I forget. So there is a testicular lump in a 25-year-old. This mass is firm, it's painless, and it's rough. Good. And laboratory result shows lactate dehydrogenase level, so elevated. The rest of them are decreased. Testosterone is decreased. Let me change color so we can differentiate. Testosterone is low, estrogen is low, alpha fetoprotein is low, human chorionic gonadotropin is low. So what is your diagnosis? This should be straightforward testicular cancer question. That's what it is. Teratoma, what do we know about teratoma? Teratoma is made of three germ layers, all three germ layers. Germ layers. Let's know what are those germ layers: endoderm, mesoderm, and ectoderm. Okay. Remember, during the third week of embryogenesis, the fetus or the embryo is made of three layers only. Those, what are those three layers? Going from inside to outside: endoderm, mesoderm, ectoderm. Okay, so that's what they're talking about. So the three teratoma is made of all those three germ layers. Those germ layers have the potential to produce any kind of hormones. Okay, so but anyways, these germ layers usually, so you'll find in this all kinds of tissue, all three types of tissue. You may find tooth, bone, cartilage, hair, okay, and some other endocrine tissue. What is the marker? So oh yeah, let's look at it this way. If I want to diagnose testicular cancer, number one, so all of them will be firm, painless, rough. So that doesn't help me. What helps me is marker, serum markers, to differentiate between them, to see which type is it. Teratomas, seminoma, androblastoma, choriocarcinoma, all these are testicular cancers. That's number one. I'm in a rush, so I'm going to do a little bit quicker. This one, serum markers, we look for that to differentiate between testicular cancer. Second, we look for biopsy tissue. What do we see on, what would you find on biopsy? So that's what I'm going to focus on. I hope you guys bear with me with that. Okay. um, can this be abscess? Absolutely not. Abscess is painless, fever, and tenderness. We don't see that in this patient. This patient's mass is firm, painless, and rough. Okay. Spermatocele, we already talked about spermatocele. It's fluctuating mass, not a firm mass. So that's not it. Lymphoma, yeah, absolutely. The rest of them are possible. So we're going to look for these two things, markers and biopsy. So the marker for teratoma will be maybe TSH. Okay, TSH, look for that. And on biopsy, what are you going to find on biopsy? Hair, tooth, cartilage, or all three germ layers. So that's how we differentiate. Seminoma, plus this occurs in teenage around the age of 12 or something like that. Okay, age. Look for that too. Seminoma occurs in a 20 years old and high. Okay, 20 years old age. So that's unique to teratoma. Teratoma is the only one that is radiosensitive. Radiosensitive. Okay, radiation will cure it. All these other tumors are radio resistant. So in seminoma, what are we looking for? In seminoma, the marker that you look for is LDH, lactic dehydrogenase. Okay, and you can find with seminoma, you can find a mature tissue. So usually in seminoma, the testes on biopsy, you'll find glycogen rich cells, glycogen rich cells. And glycogen rich cells appear like, if this is a cell, within the cell there will be large vacuoles, clear vacuole full of glycogen. Okay, so look for that. And the cells look like, the cells that you see in here don't look like cartilage tissue or anything like that. They look like spermatogonia. Spermatogonia, which is immature sperm. Okay, androblastoma. Look at the name, andro means androgens. So this will be producing androgens such as testosterone. Okay, testosterone. So I will just put T. Androblastoma. And androblastoma, because remember, testosterone is made of cholesterol, so you will be seeing this lipofuscin. Lipofuscin. Okay. Positive. So the tissue that you biopsy will be lipofuscin positive. And of course, they will also have luteinizing hormone receptor positive. And they'll be producing testosterone. So the marker, so this will be the part is for markers, okay? And this part is for biopsy. This part is for biopsy. Just so we know. Biopsy. This is for the markers, plasma markers, and then this is the age. Okay. Remember we said there's two ways to differentiate between testicular serum markers and biopsy. That's what I'm focusing. Choriocarcinoma, remember chorionic villi and chorion, those are membrane of the placenta or fetus tissue, okay? So for choriocarcinoma, in terms of biopsy, you're going to look for placental tissue. So placental-like tissue, that's what you will find on biopsy. Marker should be HCG. Remember, HCG is a marker of pregnancy, and in the chorionic villi, in the chorionic layer of the placenta will produce that. Okay. The next one is lymphoma. Lymphoma should be easy. If you do biopsy, you'll find B cells, B lymphocytes, and they should be CD20 positive or CD19 positive. Okay. Markers, they may have like, enzymes that are common in these lymphomas. So our question was lactic dehydrogenase. This is the lactic dehydrogenase, and look at the age. These are the two things that help us identify this to be seminoma. So we'll choose the answer to be seminoma. Okay, let's go to next question. So this will be the last question for today. A 22-year-old college student is brought to the emergency room because of a sudden onset severe left scrotal pain after a wrestling practice. On examination, his right testicle is swollen and raised. Cremasteric reflex is absent, and testicular support does not relieve the pain. Ultrasonography shows decreased testicular venous drainage. Which of the following is the cause of these symptoms? Is it epididymis infection? Is it scrotal trauma? Is it testicular artery embolism? Is it spermatic cord twisting? Is it vas deferens tear? Let's diagnose this first. What are we looking for? What do we have here? Let's highlight some of the main symptoms. So this person is a college student. He's a wrestler, and after the wrestling, he suddenly develops severe left scrotal pain. When? After wrestling. So that's some sort of trauma. His right testicle is swollen, so testicular swelling, and it's raised. Cremasteric reflex is absent, and testicular support does not relieve pain. All of these things for me is 100% testicular torsion. You should understand and memorize these things. It would help. So testicular torsion. Okay, testicular torsion. So if this is the testes, remember testes have a spermatic cord. So this spermatic cord within have the testicular vein, and it has within it vas deferens. Let's use gray. And within it, it has the testicular artery. If this twist, take a rope, or just take the cable of your laptop, a cable or wire or whatever, your phone charger, just twist it. When you twist it, see what happens. This is what happens exactly. So when you twist this spermatic cord, it's going to cut off blood supply to the kidney. So the end result of this is testicular ischemia. And remember, this is sudden onset, acute testicular ischemia. So when the testis doesn't receive blood, the first thing that will happen is severe sudden onset pain. So we'll look for pain that is severe and sudden in onset. Okay. And damage or ischemia or necrosis eventually can lead to necrosis or infarction of the testes, which is the worst case scenario. We don't want that, right? So it can lead to swelling. So this person has pain, and this person has swelling. Where is the swelling? Sorry, right here. And all of this would be caused by trauma. So this person has trauma. Now the next thing is, if you touch the inner thigh, the groin area, the inner thigh, there should be cremasteric reflex where the testes will will elevate. Okay, will just like when you touch it. So the cremasteric reflex is absent in this case. That's unique to this for torsion. Okay, is absent. So look for that. Very, very important. Now, if you elevate, testicular elevation. Of course, you're going to put on gloves and you will with your own hand with gloves on. You will elevate the testes that are affected, in this case the right testes. You will elevate it. It should relieve the pain if it's orchitis or testicular inflammation or epididymitis. If it's torsion, it doesn't cause. The pain is not depending on position, just like when we talk about angina. Okay, elevation does not relieve pain. Okay, uh, does not does not relieve the pain. So these are unique. If you have sudden onset of testicular pain and swelling and cremasteric reflex is absent and testicular elevation does not relieve the pain, this should be 100% testicular torsion. Okay. All right. Now that you have diagnosed, oh my God, so you be suspicious at this point. It still doesn't confirm it, you're suspicious. So the next thing you do is ultrasound. You can do pelvic or abdominal ultrasound. Okay, so not abdominal, sorry, unless it's undescended testes, my bad. Pelvic ultrasound or testicular ultrasound, what does it show you? Decrease blood flow to the testes. Okay, and the solution is detorsion. It's an emergency, you have to take him to the operating room. This question should, I just seen it, it shows decreased testicular venous drainage. Okay, ultrasonography shows that. Okay, if that is the case, then that means we discussed that this will be twisting of the spermatic cord. Is this epidermis infection? No. Is this scrotal trauma? No. Testicular artery embolism? No. That'll be testicular infarction. Spermatic cord twisting? Yes. That's your answer. Okay. All right. Thank you guys for today. I'll see you guys tomorrow.